Hello, and thank you for watching this recording of this presentation called Recognizing the Signs, a Guide to Ectodermal Dysplasia for the Oral Health Professional. My name is Richardson, and in collaboration with my classmates, Hazel Miles, Brianna Gabriel, Samantha Haydar, and Ayman Allakany, supervised by our faculty advisor, Professor Denise Zwicker, we would like to present our presentation on ectodermal dysplasia and its importance for oral health professionals. So I want to begin this presentation with describing a patient presentation. So this following patient is a 14-month-old male. He's ASA class 1. He's presented to the dental office for his first dental visit with a chief complaint from his mother that he has not had any teeth erupt and has exhibited no teething behaviors. So based on the health history, the patient is currently experiencing recurrent overheating, respiratory infections, has thin, dry hair and skin, and is having difficulties with feeding and gaining weight. Upon examination, the dental hygienist found that there was reduced salivary flow and xerostomia, deficient alveolar ridges, severe facial eczema or skin irritation and redness, hyperpigmentation around the eyes. The patient also had a prominent forehead, low nasal bridge, and there was an absence of a lingual frenulum. So the case from the previous slide was taken from a real patient. This patient's name was Jacob Howard, and he was diagnosed at 14 months old with hypohidrotic ectodermal dysplasia, also abbreviated as HED. He was initially diagnosed by his oral health care provider during his first dental visit and had no family history that was known of at the time of any form of ectodermal dysplasia. Without visiting the oral health professional, a lot of Jacob's symptoms were explained away with other instances or other conditions, and without having seen the dental hygienist who urged the dentist to perform an exam and explore further, Jacob may have gone without a diagnosis for quite some time. By the end of this presentation, participants will be able to describe characteristic features of ectodermal dysplasia, also abbreviated as ED, recognize the importance of ectodermal dysplasia awareness to the dental hygiene process of care, identify different treatment options and their outcomes, and identify how ectodermal dysplasia targeted care changes with the life stage needs of the patient.
The term ectodermal dysplasia includes 186 distinct genetic mutations with various heritability patterns. Types can vary in clinical presentation, making accurate diagnosis more difficult. Ectodermal dysplasia is rare. It is diagnosed at a frequency of 7 in 100,000 births. On the next slide, I will give insight in how ectodermal dysplasia might affect your patient. As budding or budded clinicians, we are familiar with the term dysplasia as it refers to dentin or enamel. In ectodermal dysplasia, multiple structures derived from the ectodermal cell line, one of 3 primordial germ layers, present as dysplastic. These structures include the skin, hair and nails, sweat glands, salivary glands, and teeth. The most common presentation of ectodermal dysplasia is hypohidrotic ectodermal dysplasia, with the clinical triad of sparse sweat glands, sparse hair, and hypodontia. When ectodermal dysplasia is anticipated due to family history, dysplasia in ectoderm structures can be even detected in utero. The sonographic image on the right shows a comparison between infants, 18 to 28 weeks, with and without ectodermal dysplasia. The arrows indicate fetal tooth buds. Some of the oral and perioral complications arising from ectodermal dysplasia, especially if late diagnosed, are xerostomia due to hypoplastic salivary glands, growth delays associated with feeding difficulties, mid-face hypoplasia, speech delays, and self-esteem issues.
To conduct our literature review, we used the following databases: PubMed and DOS. Our keywords for our literature review included ectodermal dysplasia itself, treatment or intervention, dentures or denture, implants or implant, and dental management. All papers included had to follow our inclusion criteria of being written in English, including our keywords, published within the last 10 years, and be peer-reviewed sources. Our exclusion criteria included editorials and letters to the editor or non-peer-reviewed articles or papers. In total, 23 articles met our criteria. 6 of these were case studies, 15 were literature reviews, 1 was an international expert consensus study, and 1 was a systematic review. The major themes that were exhibited in our 23 articles were the process of ADPI, treatment modifications by age and clinical presentation of patients, preparation of patients for both surgical and non-surgical interventions, as well as early treatment options with their long-term follow-up in these patients.
Ectodermal dysplasia affects ectodermal structures. So patients with ectodermal dysplasia will have extraoral features like dry, lightly pigmented sparse hair. Also, we could find deformed or brittle nails, dry and hypopigmented skin, heat intolerance, leak or reduced sweating, which causes skin redness and irritation, mid-face hypoplasia, and saddle nose. Saddle nose, where there is a collapse of the middle part of the nose, the nasal bridge, and loss of the nasal height. Also, there is respiratory difficulty, which is associated with the absence or poor development of the mucus gland in the respiratory tract. Regarding intraoral features, will include xerostomia from the hypoplastic or absence of salivary glands, alveolar ridge defects from the absence of the teeth, and lip protrusion also is noted, oligodontia, anodontia, the hypodontia. Oligodontia is a congenital absence of 6 or more teeth. Hypodontia is a developmental absence of 1 or more primary or permanent teeth. Anodontia is a complete absence of teeth. It was also found the presence of conical or pointed incisors, abnormally shaped molars which are reduced in diameters, thin soft-pitted enamel, and abnormal root formation and root resorption.
As ectodermal dysplasia presents with a diversity of symptoms, there are a wide range of available treatments, not all of which will be appropriate for each patient. Thankfully, the province of Nova Scotia provides fee-for-service coverage for those whose maxillofacial prosthodontic needs result from congenital facial disorders, cancer, trauma, and neurological deficit. One thing agreed upon is the value of early intervention in addressing the patient's psychosocial, masticatory, and orthognathic conditions, as well as impacting their growth potential. One knock-on effect of anodontia is reduced alveolar ridge development. Dysplastic enamel increases the caries risk of some patients with ectodermal dysplasia. Dental practitioners will have to manage this risk in combination with the hard and soft tissue complications of xerostomia. The prosthetic treatments available range from conservative treatments, such as partial dentures, as shown on the left here, to more invasive procedures, such as pediatric implants, bone grafts, or zygomatic implants. Pictured in the center here are implants to support prostheses in a 7-year-old girl with ectodermal dysplasia. On the far right is a radiograph of an adult with zygomatic implants, which is an alternative to bone grafting when the alveolar ridge is insufficient.
For the process of care of children with ED, in terms of referrals, we want to refer young children with ED to a dentist for early prosthodontic interventions. And it's recommended that these children wear removable dentures early, between the ages of 3 and 5. Removable dentures can promote proper alignment of the jaws during craniofacial growth, improve speech, improve mastication, help maintain a nutritional diet, provide favorable aesthetics, and improve social life and self-image. Additional referrals, such as to a speech pathologist or nutritionalist, might also be necessary. In terms of assessment, it's vital that young patients with ED undergo close continued monitoring because their jawbones and facial structure are growing and developing at a rapid rate. This means that the need for continuous remakes are often necessary. At each appointment, the dental hygienist should check the fit and integrity of the denture and refer the child to a dentist if necessary. In terms of implementation, the dental hygienist should provide personal oral hygiene instruction, which includes care of natural teeth, care of dentures, and options for alleviating symptoms of xerostomia or hyposalivation. This includes drinking water or using xylitol lozenges. The lack of saliva in combination with the thinner enamel of primary teeth will put these patients at a high caries risk. Therefore, fluoride application is also warranted. Process of care for ectodermal dysplasia in adults and elderly. In terms of assessment, first we must review the health history. This is because an increase in age is highly correlated with increased prevalence of many systemic conditions and a general increase in use of medications. Both systemic conditions and medications can have negative consequences to the oral cavity that can affect a variety of different dental prostheses in many ways. Being aware of these and making appropriate referrals is necessary. Next, we must conduct an intraoral examination. We want to take note of any characteristic signs of ectodermal dysplasia, such as hypodontia, abnormal tooth shape, and xerostomia. Next, we must evaluate probing depths around existing teeth and implants to assess the condition of the surrounding periodontal tissues. For denture wearers, we must also closely examine for signs of stomatitis, which may be indicative of inflammation and require intervention. It's also crucial that we assess for natural intraoral changes that occur due to aging. These include hyposalivation, increased caries risk, reduced wound healing, and a decreased density and height of the alveolar bone. These changes can also affect the success of many prostheses. Therefore, the dental hygienist should assess for the patient for these changes and make appropriate referrals or treatments if necessary. We must also conduct a radiographic examination, where we assess bone levels to determine adequacy for future implant placement and stability of existing teeth, and check the status of existing implants, assessing for any signs of peri-implantitis or other complications. The frequency for radiographic examinations is prescribed by a case-by-case basis. In terms of implementation, we want to conduct debridement of any present teeth and fluoride application due to increased caries risk, denture and implant care as required, and extensive oral hygiene instruction. We must provide a tailored OHI education session to the patient addressing specific care needs that may be related to implants, dentures, or implant-supported prosthesis. We must emphasize the importance of overall good hygiene practices to properly maintain the health of any natural teeth and prosthetic appliances. During implementation, it's also important that the dental hygienist provide personalized OHI that considers the patient's physical and cognitive limitations, if any. For example, dementia is common among elderly patients, therefore, providing information on a written document or giving it to their caregiver is necessary. Any relevant information from the med history that you gathered in the assessment phase should also be included in the OHI session. For example, many medications cause hyposalivation. This can greatly impact the comfort of denture wearers. Therefore, we want to recommend xylitol lozenges or biotin products to alleviate those symptoms. In terms of collaboration, we must work closely with the dentist for all prosthetic interventions and modifications to any existing interventions if necessary. We will work in tandem with the dental team to optimize the fit and function of the prosthesis to ensure patient comfort and efficacy. A referral to a medical doctor may be necessary to alleviate hyposalivation using a prescription medication called pilocarpine. Limited research exists on the impact of pregnancy on the periodontal ligament and alveolar bone. However, there is well-established evidence supporting the connection between female sex hormones and gingival health. Estrogen and progesterone play a role in modifying host response factors, contributing to the development of pregnancy gingivitis. This holds a particular significance for individuals with ectodermal dysplasia, emphasizing the importance of proper maintenance and gingival health for the longevity of implants and denture wear. The presence of gingivitis has the potential to compromise the stability of implants and create a pathway to peri-implantitis. This poses a threat to the long-term success of the implant. For individuals wearing dentures, gingivitis can intensify gingival irritation and lead to discomfort and possibly even an improper fit of the denture.
Lessons learned. Ectodermal dysplasia is comprised of 186 different genetic conditions affecting ectoderm-derived structures. Every patient will have a unique presentation. As a product of missed diagnosis, interventions, which are key to supporting a patient's quality of life, may be delayed. Treatment should be personalized to each individual, as there are many treatment options without clear international consensus, such as implants in pediatric patients. As dental hygienists, we play a key role in the management of cases of ectodermal dysplasia. Zygomatic implants may be an alternative to bone grafting and prosthetic rehabilitation.
In conclusion, dental hygienists are key players in ectodermal dysplasia care and diagnosis. Optimal outcomes are achieved through early intervention. So as discussed earlier, children aged 3 to 5 should be referred to a dentist for fabrication of removable dentures. As well, individualized care is critical. Treatment management options are diverse and innovative approaches should be considered for every patient. Finally, interprofessional collaboration should be emphasized. This includes referrals. We extend sincere thanks to Professor Denise Zwicker, the project advisor, Professor Haslam, the course director and mentor, and Shelley McKibben, the Dalhousie librarian.